an annual report documenting the use of both existing and new-to-market orphan medicines and technologies in Ireland, and a summary of applications received and decisions relating to these applications should be made publicly available. The existing horizon scanning between pharmaceutical companies and the HSE, including clinical value assessment authorities, should be enhanced to improve information available regarding orphan medicines and the pipeline and the future needs for these medicines. We ask that the HSE apply a set of guidelines on the prescribing of orphan medicines and the technologies in Ireland and evaluate clinical outcomes regarding use of orphan medicines. We recommend that the early dialogue between the HSE and companies who are running clinical trials in Ireland with Irish patients where licence approval is imminent. Sponsors could be offered the incentive to run trials in Ireland, increasing access to innovation for Irish patients. The principles of Patients Empowered are integral to all aspects of the National Rare Disease Plan for Ireland, both now and into the future, in recognition of the fact that these patients and their carers require significant clinical and non-clinical support. We are calling for an oversight implementation group of the relevant stakeholders, including patient groups, led by the HSE, be established to oversee and monitor implementation of the National Rare Disease Plan's recommendations and associated key outputs. The HSE will report to the Department of Health using key performance indicators on a periodic basis in accordance with reporting requirements under the National Service Plan. It should be noted that the European Union have mandated USAID KPIs and that Ireland must report on these actually by the end of this year. There needs to be an overall review of the National Rare Disease Plan prior to development of the next plan in 2019. As patients and representatives of patients, we welcome the recent commitment on the establishment of a National Office for Rare Diseases. This will facilitate the coordination and timely access to centres of expertise nationally and internationally, and will provide information regarding new treatments and management options for patients and medical professionals. The information already outlined to you today highlights how the Rare Disease Office will be a cornerstone in the facilitation of many elements of this plan, but it must be sustained and built into the future. We remain in a time of economic constraint. We are, of course, aware of this, but we strongly believe that the name rare should not be understood to mean few. Investment in this plan will lead to considerable savings for the Exchequer, and not just in the long term, but today and tomorrow. Patients on the diagnostic odyssey are, as we speak, being moved from department to department in hospitals or between hospitals and between counties. They are lying on trolleys, helpless and untreated. They are the people who will benefit from the implementation of this published plan. EU structural funds and investment funds are instruments used to support economic, social and territorial disparities that exist across the Union. They are designed to promote greater cohesion in these regions. They therefore form the basis of an EU cohesion policy, providing the investment framework to deliver the Europe 2020 objectives of smart, sustainable and inclusive growth. A key area highlighted in this instrument is social inclusion. The amount to be invested in 2014 to 2020 is €352 billion, representing 1/3 of the total EU budget for the next 7 years. Each member state is allocated a portion of this global amount. We ask then why these funds could not be considered as a means by which a programme of this nature, with this focus, can bring these patients and their families living with rare diseases out of the shadows and the margins of society by enabling them to become active citizens who will contribute day by day, hand in hand, to a more inclusive, cohesive and productive society. Thank you.
Thank you very much indeed. And our final speaker is Ms. Helen Byrne. Ms. Byrne, you're welcome. Thank you very much.
Thank you for the invitation to attend the committee meeting today to discuss tackling rare diseases. I am joined by my colleague Dr. Colm Henry, the National Clinical Advisor and Group Lead for the Acute Hospitals. The Department of Health's first National Rare Disease Plan, a Rare Disease Plan for Ireland 2014-2018, was published in July 2014 in line with the European Council recommendations. The National Clinical Programme for Rare Diseases in Ireland was initiated in December of 2013 under the National Clinical Strategy and Programmes Division of the HSE in collaboration with the Royal College of Physicians Ireland, with the view to improving and standardising the quality of care for patients with rare diseases in Ireland. Professor Eileen Tracy is the clinical lead and a programme manager have also been appointed to the programme. The key initial priorities for the clinical programme are to assist with the identification and the designation of national centres of expertise, with the view to having the option to join the European reference networks, to facilitate the development of a national rare disease office in line with the European Information Portal for Rare Diseases, Orphanet, and for the development of care pathways for the more common rare diseases. The National Clinical Programme on Rare Diseases developed a business model for a National Rare Disease Office in 2014 and applied for entry to the EC Rare Diseases Joint Action. Funding for 2015 has been allocated, as previously stated, to the office for the following staff: a full-time information scientist, half of which will be funded by the EU for a period of 3 years, a genetic counsellor, a consultant geneticist of 0.3 of a whole-time equivalent, and administrative support of 0.5 of a whole-time equivalent. Recruitment for the information scientist is currently underway. The 4 main functions of the National Rare Disease Office include building information on the availability of expertise in Ireland for rare diseases and making this information available on the Orphanet website as a resource for both patients and clinicians. A helpline for patients with access to a genetic counsellor, support the HSE in mapping and validation of the centres of expertise in Ireland, and long-term a role in rare diseases surveillance. The National Rare Disease Office will be based in the Mater Misericordia University Hospital, pending the establishment of the National Children's Hospital. It is hoped to launch the opening of the National Rare Disease Office in late Q2 2015. The core benefit to the population and the state of the establishment of a rare disease office will be the streamlining of access to diagnosis for patients and appropriate quality treatments with increased efficiencies in the delivery of care. Professor Eileen Tracy, the clinical lead, is the designated coordinator for the island of Ireland and the designated person to participate in the EC Joint Action on Rare Diseases. Her work will include establishing and validating the Orphanet information and function in Ireland through the National Rare Disease Office and the dissemination of information nationally for rare diseases. Her participation in this project is due to commence in May 2015. The HSE National Clinical Programme for Rare Diseases with the Acute Hospital Division is currently embarking on an exercise to identify and designate existing centres of expertise for diagnosis, multidisciplinary care, clinical research and training in rare diseases according to accepted European criteria. The initial sites to be reviewed for the 3 major services being considered for 2015, early 2016 are clinical genetics in Our Lady's Children's Hospital, Crumlin, the inherited metabolic disorders in the Children's University Hospital, Temple Street, and hereditary coagulation disorders, St James's Hospital and Our Lady's Children's Hospital, Crumlin. This work will also inform the identification of centres of expertise abroad for those patients whose disorders cannot be fully served in Ireland, in collaboration with European reference networks, and the development of processes for patients to access this expertise for timely diagnosis and care. As a member state, we have obligations under EC Directive 2011/2014 EU, which is application of patients' rights in cross-border healthcare. This directive is of particular relevance to patients with rare and ultra-rare diseases. This directive on the application of patients' rights in cross-border healthcare will strengthen cooperation between highly specialised healthcare providers across the European Union by the establishment of a system of European reference networks. Establishing European reference networks of highly specialised healthcare providers will help to provide affordable, high-quality and cost-effective healthcare to Irish patients, requiring a particular concentration of resources or expertise which may be available in Europe, but not specifically in Ireland. European reference networks for rare diseases should serve as research and knowledge centres, treat patients from other EEC countries, and ensure the availability of subsequent treatment facilities where necessary. The HSE has established a national contact point to facilitate information regarding the Treatment Abroad scheme and the Cross-Border Care Directive, and further information is available on the HSE website. It is hoped that the National Rare Disease Office will, in time, also assist with and facilitate the national contact point for queries involving rare disease patients. A recommendation of the National Rare Disease Plan was for the National Clinical Programme for Rare Diseases, through a National Office for Rare Disease, develop the clinical and organisational governance framework that will underpin care pathways and access to treatment for rare disease patients, particularly in the context of the transition from paediatric to adult care. The National Clinical Programme for Rare Diseases has now assembled a subgroup to develop a model of care for this work. This concludes my opening statement, and together with my colleague, we will endeavour to answer any questions that you may have. Thank you.
Very much indeed. Now hand to Deputy Keller. Deputy Keller, 5 minutes.
Everybody here today, just to say that at the outset, I suppose on foot of reading the Rare Diseases report, I mean, it's quite evident that we have an awful lot to do in this country. Let's be very honest, we're starting at a very low base, to say the very least. And what we need, first of all, is commitment that it should be done. And then we need resourcing of same to ensure that it is done. And that in itself is, is going to be a huge undertaking, but it shouldn't deter us from doing what we need to do and doing what's right. Just a few issues that are very obvious in the report and from the presentations here today as well. We talk about rare diseases. They may be rare, but collectively they're quite substantial in number. And that's quite obvious and evident in terms of across the European Union as well. And I often wonder why there isn't more collaboration, transnational collaboration between national bodies, research institutes. I mean, we're a population of less than 1% of the European population. Will we have enough critical mass to do our own research? Will we have just enough support and the capacity to do that? And I'm just wondering, at times, are we a little slow and reluctant as a nation and as a union to collaborate in a meaningful, planned way done through national governments and national agencies on a one-to-one? And I just think that there's a lot of work there that could be done and should be done. That's not only in the context of research, but also in the area of treatment and providing supports. And certainly that is something that I think the National Rare Diseases Office and its equivalents across Europe must come together in a more defined, targeted way. In the area of research, for example, you have research sort of scattered around, and obviously research by its nature, is that there has to be some way of pooling that together between industry, the hospitals, universities, coming together in a more collaborative way at times. And I said that we all understand the nature of research is that it's, can be secretive in its nature initially, but there should be some better pooling of resourcing. I spoke last week in the Dáil on the National Centre for Medical Genetics. I'm still unclear. What's happened? Why is it gone? I would have assumed at this stage we'd have understood the importance through the advances in medical science and embryology and stem cell research and everything else, and the assessment of genetics and chromosomes, that we would be actually trying to enhance our National Genetics Office, not trying to undermine it. Like, what is happening with us? And I was raised in the Dáil last week, and I got, I must say, sort of a very poor answer, to being truthful. And I think that if we are serious, and if there's a commitment to a National Rare Diseases Office, one of the singular largest elements of rare diseases is the whole issue of genetics. So genetics, genetic testing should be a central focal point. So if I could get some answers on that, I would greatly appreciate it. I was just looking through the list of rare diseases. The vast majority of them are genetically, yes, yeah, it's 80%, is it so? So if we could get some assistance on why that seems to have disappeared, been undermined, been chastised, whatever has happened, something's happened, our National Rare Diseases Office anyway, at a centre, and we should address that. I think an issue of major concern, and probably many TDs and senators and public reps would have been in here and in the Dáil in general, would have been on this journey with families from time to time, where a family gets a diagnosis of a rare disease. And the system is just unable to tell them exactly what it is. They may have been some time before they got the diagnosis. When the diagnosis comes, the system can't really support them that well initially. And the family are left very much on their own, other than goodwill support. Now, don't get me wrong, other than goodwill, but the actual system itself. They're very often trawling through the internet, trawling through reams of research data to try and find answers, cling to hope at times, and it can be a very, very difficult journey. And I'm just wondering, in that context, while we have a proposal for a National Rare Diseases Office, is there any way we can humanise the bureaucracy through the system? And I know that's always difficult to humanise bureaucracy, but I do believe that it can be harsh at times, not in an intentional way, but just because of its bureaucratic nature, particularly with families with rare diseases and individuals with rare diseases. Just in practical areas, kitting out of houses, maybe the willingness, for example, for the bureaucracy or the HSC or anybody to help the local GP, for example, to get that extra bit of training to assist with that maybe one patient they'll ever have with that rare illness. So I just think there's certain areas where, you know, maybe from looking for the top down is one issue, but maybe just assisting GPs, nurse specialists in communities from time to time when there's a specific illness or disease with one patient, one family, that, you know, that should be done. And I think that might help alleviate some of the pressures that families are under from time to time. I've much more to say, but sure, it may be repeated, and I can, yeah.
Dr. Quillan.
I want to very especially welcome our panellists here this morning, and not just our panellists, but all our guests here as well, and to say you're all very, very welcome. I think it was a wonderful idea to dedicate a day in the year to International Rare Diseases Day, because it has allowed us to have a hook on which to hang this focus. And the focus mightn't happen only but for. I want to thank all my colleagues on the committee for the support annually in this address. A number of points. In listening to Avril's presentation, and I'm not making a distinction one from the other, they were all very, very informative. But when she talks about a dedicated facility, she describes a facility to coordinate the information flow, the provision of expertise locally, regionally and internationally to a national coordinating centre. The centre or office will be responsible for developing appropriate pathways of care and would undertake epidemiological work, be equipped with appropriate IT infrastructures and coordinated information systems to allow for the development of registers that will enable better planning of services and facilitate the development of research infrastructures. Does that equate with the National Office for Rare Diseases? It should, but I don't know from the outline. Mr. Devlin and Helen, I'm not certain, it's Helen, no, I used the first name. I'm not certain that what Avril has actually said and that I believe is needed is what's actually in the plan. When we look at, and we received correspondence here, my colleague Senator Burke made reference to it only, I think, a week ago, that the National Office is getting ready. And I mean, it can't happen soon enough. But when you take a look at the outline of what's intended, You know, we have one whole-time equivalent information scientist, one whole-time equivalent genetic counsellor. We have 0.3 of a consultant geneticist, and we have 0.5 of an admin support. I wonder what half it would be. You know, really and truly, what's outlined here, and I'm hoping, John, that you will be able to advise that this is just the initial commitment, because it doesn't equate with what I believe and what I believe all who are interested in a real and serious focus on rare diseases know is required. And I would hope that what Avril has described is where we're going to get to, and I would very much appreciate if you would advise what is the real plan in relation to this national office, because there are so many aspects of what's needed not signalled at this point in time. The registries, I think that's absolutely vital, and I think it's hugely important, and I also strongly concur with the approach on an all-island basis, living as I have and spent my lifetime 4 miles from the border. I mean, the people that I know within my catchment all bear the same names, all face the same problems, and are all part of the same genetic makeup, you know, as each and every one of us. And many of the representative organisations are actually structured on an island basis, and it is very, very important that this cooperation is there, or we won't get the full picture. We need to get a picture, an Island of Ireland picture. Will the National Office be helping to develop these registries? Is that work that you would expect? I would expect that some of that work would, you know, require more than the scientist and the counsellor. You know, the admin staff would be taking on a lot of this work, the IT requirements in terms of it. I mean, I think that database is absolutely vital and a hugely important component part of everything needed going forward. The situation in relation to, and Deputy Kelleher also referred to it, you know, we no longer have a National Centre for Medical Genetics. My understanding is now it's reduced to a department. Is that the case? That we don't have, well, what I understand, Crumlin Children's Hospital have downgraded the National Centre for Medical Genetics to a department within the hospital. Can we just have some further information in relation to the status of that at this point in time? And given the fact that the greater number of rare diseases are genetically based, why in heaven's name would we, when we're setting off to hopefully seriously address the deficiencies in relation to rare diseases through the establishment of a national office, why would we see the downgrading, if not the elimination of, you know, a medical genetics department, the only one that we currently have had or have had up to now? Bear with me just one little moment, Chair. The oversight, there seems no oversight in relation to the National Rare Disease Plan for Ireland. There isn't an oversight committee, as I understand, and I wonder if it would be possible to advise, is that under consideration? Will that be introduced? And why, with all of the attention and focus, was there almost no referencing to national rare diseases, let alone the office in the HSE service plan for 2015? It baffled me going through it, and I'm still at a loss to understand why it wouldn't have merited, if this was a serious embarkation to address rare diseases, why would it not have been a critical part of it? And the very last thing, just with your indulgence, Chair, I want to thank Tony and all the work that is being done. And, you know, as a parent who has had the direct experience, your testimony here today is, you know, very important and striking. But the one thing, I mean, there are many points that I'd like to explore with you further, but there is one that you refer to that's particular to you, and that is on the diagnosis of a rare disease within a family. As a parent, what that actually means in so many, many ways. It's not only the terrible tragedy of the onset of that news, but it is, as you say, the consequential difficulties that present in relation to employment and financial security for you, your wife, your family. That is an area that needs to be addressed, and we need to have a joined up response to situations of particular difficulty and hardship that must and do present where a rare disease presents in a family. And I want to thank you for drawing attention to that here this morning.
Thank you, Deputy. Senator Van Turnhout.
Thank you very much. And I too would like to welcome you all, and like my colleagues, I think the fact that we have a day each year to focus actually gives us also as a committee an opportunity to focus on the issue, although we do have other encounters during the year. And certainly I was, in preparing for today, I looked back on the 15th of January. We had the Huntington's Association, for example, in with us before the committee, and for me they raised some really important issues, as you have done so today. And I think Avril's words rang true to me about that rare doesn't mean few, and I think when you look at the figures and the numbers, when you collect together, it is quite significant, and it is quite a significant health issue. But also when I see the number of children directly affected, the prevalence obviously in childhood, and the number who die before their 5th birthday, obviously makes me wonder, well, where should we be going? And that's where I come to Tony's presentation. And I suppose I'm a bit like Tony in the sense of I want to see the implementation and the action. It reminds me of the last time Ireland was before the UN Committee on the Rights of the Child. The committee said we were very good on paper, but the implementation piece, and I think that's where I would like to focus is, you know, we called a report at the time From Rhetoric to Rights, and how do we ensure that these rights are realised. So for me, the specific questions I'd like to be asking, firstly, the point that Tony raised about the Oversight Committee must include the previous members of the steering group as a minimum. And I just want to know is why is there a question mark over that? And maybe people could explain to me what is happening in the process of the Oversight Implementation Group. I think it's really important that it would bring together the expertise. So I'd be interested to know more about that. In reading the plan, I assumed the implementation group was there. So that's my, you know, because we really need to move to implementation. So I'd like to know what's happening, because I think it's very important. The other is on the genetics issue. It's an issue that I raised with the Huntingtons. Is there a genetics unit, do you know, planned within the new National Children's Hospital? Because my understanding is that there should be, but I would like to know whether organisations individually or the HSE have been involved in the scoping in relation to rare diseases and the needs assessment for the National Children's Hospital in relation to rare diseases, not just only in the location of the hospital, because my understanding from our visit as a committee to the hospital is that they'll have satellite and they'll have services also linked to the hospital. So I'm sort of looking at that wider remit of the National Children's Hospital, not just at the building and the physical premises, but that supports that they will provide and the coordinated support. So I'd like to know specifically if you know that organisations, have they been actually involved in any scoping or needs assessment, because I think it would be critical that they would be at this time. The other issue that was raised for me, that the credible source of information needed, and I would like to know what developments are happening on that side, because I think we all turn to the internet now and online, even though we know diagnosis-wise we're not going to get, but it's the only place. Sometimes you feel you may get answers, and I certainly know for people when you do even visit our medical services, and while they try to convey to you, you know, we don't always take in all the information, so you go home trying to research and find out more. But I think the issue of credible source of information, and the rare diseases by their very nature are rare, so how do we find that in a coordinated way? And I think you've raised those issues, but I'm just wondering what steps are there for Irish parents, because I see the pressures that are on the support groups, the NGO groups, that they're not getting the supports. Those who do, like, we will get testimony after testimony here of the important works that is happening by advocates working in the area who are really able to, usually coming from parents who've been through the process, unfortunately themselves, but are therefore able to translate and understand what this parent is going through or this individual is going through in their own individual case. So I'd like to know about that. The other issue is, Tony, you raised about Leams Lodge and your developments, which obviously is something to be applauded. And I just wonder, has there been any state involvement or any state interest in what you're trying to do as the CR2 Foundation in developing and doing Leams Lodge? Because certainly the work of Bumbulance, anybody I know sings its praises. I think it's for such a potentially scary time for a child that you're providing this environment. I think is something that we all have to strive harder and see, and it's one of the issues that we've raised also with the National Children's Hospital, is that it's there for the whole gamut of the child's age. So we're not just dealing with a very young child, but like that we do, you know, they're teenagers as well, will have rare diseases, and we need to ensure that we also deal with that. So they're the specific questions I have to ask. Thank you.
Two other speakers indicated, so I'll take them now, Senator Burke and Senator Crown. Senator Burke.
Thank you very much, Chairperson, and I'd like to thank everyone for coming along this morning, and for everyone for their dedication and commitment in this whole area. And I suppose when I came across it first 3.5 years ago, it was a case of everyone kind of trying to fight their own corner, which is extremely difficult, and I think it's extremely important that we all work together to try and come to give assistance and help to families where there's a member of the family has a rare disease. One of the issues I just want to raise, and that's in relation to the cross-border healthcare directive, the EU directive of 2011. I'm just wondering, could I clarify if that actually has been transposed? Because my understanding is that it hasn't been transposed, and I'm open to correction on that. And as regards, have we got any kind of idea as regards when it will be transposed? And I suppose the second issue is in relation to the treatment abroad at the moment. One of the problems, and I think all our Oireachtas members have come across this problem about treatment abroad, in some cases there's no problem and it's very efficient and it works very well. But in other cases, it's a battle that goes on for 2-3 months, and I find families totally traumatised by the whole process. And I'm just wondering, and it varies from HSE area to HSE area, and from issue to issue, or you know, the medical condition, from one medical condition to another. I'm just wondering, has there been anything put in place to try and make that more efficient and less time consuming? And it's something I think that really needs to be done, because where a family have someone who requires treatment abroad, the last thing they need is indecision, because they've already come through a fairly traumatic time, and you know that it's important that they get access and a decision on that matter. And the third issue I just want to raise is this whole issue about respite care, and Arvid and Tony might maybe talk to us a little bit about the issue of respite care and whether you're happy with the availability of respite care at the moment from your own experience of dealing with families, and do you think there could be a lot more done as regards trying to improve that for families that require it? I think it's extremely important, and I've come across a number of families recently, and I just raised it earlier before we went into the session, about where I feel families who are, you know, providing 24/7 care for a member of their family, and then they're finding they're not getting the necessary support from other services. So I'm just, and that's why I think respite care is so fundamentally important for our families. So you might just outline your own experience and feel, and maybe outline where you think there could be some improvements in that area. Thank you.
Senator Crown.
I'd also like to give a big fáilte to all of the guests and presenters who have come in today, and I'd like to beg their indulgence if I sound tired and cranky, but it's just recently dawned on me that I'm now nearly into my 22nd year of being back in Ireland and trying to grapple with some of the issues that you did with a common disease. And just a couple of points to make. We're not doing real well with the common diseases either. That doesn't mean we shouldn't try on the rare diseases. We need to, but I just would caution you on a certain issue of prioritisation. The thing which made the difference for cancer care in Ireland was not setting up the bureaucracy called the National Cancer Control Programme. It was when Michael Noonan, in about 1995, made a very public statement. I believe I may have the dates wrong. It was his first speech as Minister for Health, and he made the point that there were hospitals in the country where he wouldn't let a relative of his go with cancer, which I gently remind him was an ever so slight plagiarism of something I had said the year before, but that's fine. I was honoured that he would. And he said about appointing cancer specialists, and that's what made the difference. And cancer mortality rates started improving in this country, especially in breast cancer, which was probably the area which was most efficient in terms of available treatments not being made available in Ireland. Then, way before the National Cancer Control Programme was set up, the National Cancer Control Programme had, I believe, nothing to do with improving. It's introduced certain streamlines, but it did not actually materially affect the outcome. So please don't take this the wrong way. But I want you to understand that somebody coming away from this message would get them, from this meeting, would get the message that the country which has the smallest number of paediatricians, the smallest number of adult and pediatric neurologists, the smallest number of adult and pediatric dermatologists, nearly non-existent pediatric endocrinology despite our obesity epidemic, and very few adult endocrinologists, that what we really need as a priority to fix the management of uncommon diseases is to set up a new bureaucracy and a registry. Okay? Now, we may well need a new bureaucracy in the registry, but we're not going to fix the problem until we grapple with the fundamental structural problems of Irish healthcare, which are, I believe, nowhere nearer to being fixed now than they were when I first started pointing them out over 2 decades ago. Another core problem, I think, if you look at the places that have done best, I'm guessing, with individual rare diseases, I would, and I have not formally studied this, I have in the case of cancer. What has typically happened is that a very leading, eminent medical school-based medical centre develops an interest in the programme. And they can only do that if they have sufficient resources, sufficient personnel to allow subspecialisation to develop. Unlike the situation in Ireland where we expect paediatricians to look after, pediatric asthma in kids who come in with, all kinds of infections, and then try and give some kind of a specialist service to people who have uncommon or rare diseases. So unless we grapple with those issues of numbers and grapple with the fundamentally irrational nature of our medical schools, of having 6 medical schools in a small population, twice the European average, about 2.5 times the United States number per head of population, none of which, to be honest with you, are remotely excellent, okay? And which they were highlighting individual case people who've done brilliant jobs in difficult circumstances in building internationally recognized units, but we don't systematically approach this at all right. I have to just say something about the National Centre for Medical Genetics because I have a dog in this fight. We use genetics services primarily historically in breast cancer patients where we see a suspicious family history. We want to find out if they have a genetic syndrome which would be of great relevance to their own health and to other members of their family in terms of the early diagnosis or indeed the prevention in some cases of cancer. But the reality is we didn't stop having a national genetic centre. We never had one. We had a really good academic centre that Andrew Green, to his extraordinary credit, built up mainly on research funding, but very limited statutory funding. In fact, he and I would have had a gentle historical disagreement because we both applied for a grant at the same time for research purposes, which ended up getting his unit up and running in a large scale, and they've done a very good job with it. But he's been providing a genetic service on a national basis without having the kind of structure or ring-fenced budget that a national centre would have. So when Crumlin, in the most recent of its paroxysm of financial turmoils, as all of our hospitals did, found itself facing financial problems, they said, well, and trust me, this has happened in Vincent. I've been told over the years, don't take patients from Galway, they're not in our catchment area. We're not a national centre for any of these cancers. Make them go to their local hospital. And they'd say, their local hospital doesn't have an oncologist. They'd say, tough. Okay? That's what happens. So doctors, I believe, behaving ethically, have overcome very unethical administrative impediments that have been put in their way of providing service to patients. So, thank you. See, we're very polite down here. Good to you too. I would urge you, while undoubtedly there's a lot to be said for getting proper registration procedures and getting connected to the international networks that we can tap into the expertise, you need also become advocates for reform of the service, for reform of the number of doctors, and for reform of the structure of the medical schools. And Gurma Hagwiv.
Deputy Leclerc.
I'd like to take this opportunity to welcome you here today and to thank you ever so much for your very comprehensive presentations and particularly for sharing some of your personal experiences also. Just, I suppose, with regard to a few things that struck me, with regard to the Rare Disease Office and the staffing of it, I note that, is it an administrator 0.3 of a whole-time equivalent? You know, that's about 13 hours a week, and it strikes me that that would hardly open emails or open the post. And, you know, the fact that we have 6,000 to 8,000 rare diseases, it just strikes me as absolutely shocking. It's just something that I wanted to say. I think in your presentations you've outlined very well what needs to be done, and I think it's very simple, and it sounds extremely logical. We just need to get to that point. Also, with regard, thank you for sharing with us with regard to you know, the life-changing implications it has on families and how it affects you financially. And I think there's a huge lack of understanding there as to how rare diseases can actually affect a family and how people assess that. I also wanted to note as well from your National Rare Disease Plan for Ireland, I was looking through it last night, that between 1 in 4 and 1 in 5 of rare disease patients wait over a year for assessment by an appropriate rare disease specialist, and that respondents felt that an appointment with a specialist should follow within 3 months. That's quite logical. I mean, for somebody with a rare disease and families, the trauma of not knowing and having to wait for a year to see a specialist is just not at all in any way near acceptable. I just have maybe 2 or 3 follow-up questions with regard to CF, and maybe somebody here can actually answer them. If not, well, I apologise. But I'm just wondering how many children in Ireland are currently being treated under the trial period of the groundbreaking drug Kalydeco for cystic fibrosis. And we know that the drug can lead to significant improvements for patients with a particular mutation of cystic fibrosis. And I'm just wondering, can anybody give me an update on their progress? Have there been any side effects while they've been on these drugs? And are there any plans to extend the supplying of Kalydeco to further members of patients in Ireland? And when are the trials scheduled to continue with the CF sufferers? And does length of time of treatment vary from child to child or from age group to age group? And how will it be determined when a person should be taken off the treatment of Kalydeco? Now, I don't know if anybody can answer that, but if you can, I'd be delighted. Thank you.
Thank you, Margaret. Stephen?
Thank you, Chairman. And maybe a lot of issues have been raised. Maybe I just address some of them. I mean, first of all, I agree completely with the sentiment here that rare diseases are not rare; they're common. That's very much kind of part of our thinking. And I'm going to come back really first initially to what something Senator Crown said. I think, you know, that this struck us very early on that there really was a lack of a clinical focus with regard to rare diseases. It's a little bit different from cancer because a number of, you know, very prominent cancer specialists like yourself and everything else, I mean, we're able to take the initiative, and from that we've got a cancer program, and indeed setting up things like a clinical research network like ICOR and all the rest of it. I think that lack of focus was lacking. And I think we were aware of this very early on, and we didn't really want to wait to publish the plan. We said, look, one of the first things we got to get going here is establishing a clinical program on rare diseases. And and in fact, that led then to the appointment of Professor Alan Tracy. We talked to the then clinical director, Barry White, and he agreed to do that. So that was very important to get that clinical focus, because it was lacking. It wasn't that patients were being treated, of course they were, but there was no common themes emerging and being done in isolation in hospitals here and so on, and that really wasn't felt to be a good thing. Now, in terms of how we moved it on, I mean, yes, we can talk about structures and all the rest, but I mean, our key, what we want to do in priority initially was to start making things happen. So while we didn't have an oversight committee, what we did instead is have a number of meetings with the HSE particularly around the establishment of the office. We felt this was a priority issue to get going. And to do that, there are a number of things we need to do. We need to secure and tie down the funding from the EU and then match it then with the EU funding. And then that was the basis then for kind of the proposal then that Helen has outlined there for you today with further staff and everything else, and we can come back and talk about more whether that's sufficient or not. Deputy Keller, you raised the issue about collaboration and everything else, and of course we do. I mean, this is a pan-European wide issue, and in fact it goes across Europe. As you know, patients are treated outside of Europe as well. Yes, myself and my colleague here, Liam McCormack, are members of USERD, where all of these issues are being debated, and they're very practical issues around the development of the European reference networks, how we're going to tie into these, what the quality criteria for our centres of expertise are going to be, and all the rest of it. Now, I think it's fair to say that work has been a little bit slower being progressed than we thought. I mean, but by the end of this year, we should be in a position that we will be, countries like ourselves, we need to be designating our centres. So therefore the work that Helen has just outlined there about the National Centre for Medical Genetics for Inherited Metabolic Disease and HHC, so we would be able to kind of maybe be in a position to designate these into Europe and so on. The bit about training and everything else in medical schools, yeah, I mean, that's very much in our report. I mean, it's not that these conditions are not part of the medical curriculum. Yes, they are, but I think we need to do a little bit more. We need more information on rare diseases, and Deputy Crane, you raised the issue about registers. I think it's very interesting. If you look at our report, you'll see there's about 40 different sources of information where we had to go to get to try to build up a compendium of cases of rare diseases. And within that, there's about maybe 10, 12 registers, and some of them we're very well familiar with, like the National Cancer Registry, and it's operating under particular kind of code of governance and standards, and the Cystic Fibrosis Register. Other registers will be less developed. We also have a very strong European Congenital Anomaly Register, EuroCat, in this country. And we did have a discussion amongst the group about what the best thing to do in relation to trying to kind of bring these together, whether we're talking of a single national register or something else. And we said, look, at this point, really, it's probably more important that we, in first instance, develop a network of registers so that we could apply common standards of governance and ways of working across these registers, rather than simply to move straight into a national register for rare diseases where we really wouldn't have all of those standards agreed and all the rest of it. So that is very much part of our thinking, and that's one of the functions of the office. Now, of course, the people in the office are not the only people who will be contributing to this, because behind the other registers, you have staff working there as well, and we would fully expect they would be contributing to this work. Whether it's the National Cancer Registry, whether it's EuroCat staff and people like that, they would assist in trying to help develop this network. And of course, it would require the support of the patient organisations who themselves have developed registers as well. So I think we would be looking for that to happen too. Of course, we have legislation, and some of it enacted, the Health Identifiers Bill, and that's going to help us, and then more importantly, the Health Information Bill, because that will provide an opportunity for registers to be prescribed. And then once that happens, then they can operate then in accordance with common operating procedures and common standards, and that will make it an awful lot easier kind of when that happens. Let me see, the issue of the National Centre for Medical Genetics, I might maybe ask the HC maybe to talk to that, but I think, as I said, when we are talking about designating centres, national centres, and that is going to be one of them. I mean, so, the work that's going on about that and mapping care pathways through the National Clinical Programme and everything else, I think will then bring us to a better understanding of what we need and what that centre is going to look like. And how it then operates within a European context. So maybe the HSC maybe could talk a little bit more about that. I'm sorry, just in relation to the issue of the CF drugs, we don't have that information. It's quite specific and detailed, but we can see, and if we can make it available for you. Okay. Sorry, and maybe just some research. Maybe just leave it at that. Again, like we have. I mean, like there is a good amount of money that's going into rare disease research. Indeed, over from the HRB source alone, 2010-14, approximately 6.8 million, and it covers a whole variety of different individual rare diseases. And indeed, last November, the Minister for Health announced 1.9 million funding for rare disease as well, with through the HRB in cooperation with the NGOs. So I mean, that's very welcome. But I think I mean, there is more to do in this space because, like, Ireland isn't going to be able to solve the problem of rare disease research on itself. It's very much being part of these bigger European networks like ECRIN and ERIC, and I think these are mentioned by my colleagues here, and on biobanking as well, because you know, the very nature of these rare diseases, where some of them are so like they're actually ultra rare, means you really need pan-European research, and we would be very supportive of, you know, when the centres of expertise get designated and the clinicians take a lead in this, that they would come together, form a network and make applications as part of a broader European network infrastructure. Thank you.
Questions related to you, answer.
Okay. Predominantly the questions with regards to personal experience in getting respite and other support care services. Our own personal situation, we were offered respite in an acute hospital full of infection for a child, 2 children who were prone to infection. And any child with multi-systematic breakdowns of their immune system and other functions is not, in my opinion, or the opinion of some of the doctors who cared for our kids, the best place to put them, and that continues. At the moment, respite is exceptionally limited, if any, and where it is located is we are self-funding, without state support, transporting children from across Ireland, from Donegal to Kerry into Laurelin is one of the principal places, and kids are going in there typically for 1 or 2 nights rest after travelling for 5 hours on a bumbulance. We only have 1 bumbulance, second one on the way. But so the opportunities for respite, but we shouldn't look at the opportunities, we should look at the benefits for respite. There is a cost saving, and there's been dull questions on this. The amount of money spent by the HSE on community nursing and other such facilities in agency nursing in providing respite and support care is phenomenal. It's phenomenal. I believe it's in the region of 78 million on the question we asked over a year ago. By coordinating several areas within and provide infrastructure, as in respite facilities such as Liam's Lodge, it streamlines accessibility to in maybe 1.5 to 2 hours journey for any family to respite. Respite will give them headspace. We never got headspace. We didn't actually personally get genetic counselling. One child was already dead and the other one was nearly gone. And that was over a 5-year period. And PGD and other stuff we got, quite frankly, information which was not aligned to where it should have been. So the actual personal experiences are quite strong, and but we're trying to be proactive here. But there needs to be a greater emphasis on the patient's needs and the parents' needs. They are the 24/7 carers. They don't have, you hear figures, and I'd like for correction as well, or if I'm wrong, there's more home care packages and there's more home helps and more things, but quantify it in hours and quantify it in actual time provided to support families, not in how many families are receiving home helps and other such services, because the figures, the input and the outputs are not the same. So I do think that has to be improved drastically. While I agree with all the colleagues about collaboration of care and respite, or research and everything else, practical stuff can happen now. There are many people there. The Rare Disease Office identified, and it's welcome, a good start to a certain degree. But if you look at the whole time equivalents and the budgets, and you look at the volume of people, it's about €1 a head in year 1. That's the investment. You're talking 6 to 8% of the population in their lifetime, 275 to 330,000 people, and the initial budget is €1 a head. We need to prioritise and get the respite done as well.
Evelyn?
Thank you. Thanks to everyone. I'm Evelyn Mulroe from iPOSI, and I just wanted to come back on the comment that was made by Deputy McLennan about cystic fibrosis and clinical trials. The product ivacaftor was in clinical trials, but it's now on the market. So patients in Ireland would have had access to the clinical trial, and it kind of goes back to what Senator Crine was talking about earlier in the context of registries. We are in a position in Ireland to attract research into this country for cancer and for cystic fibrosis because we have a registry of patients. And we have information on patients and their clinical and personal information that's necessary to access trials. So registries are really important in the context of research. But I want to go back to Professor Crine's point on specialist care, and I think he's right. Eurordis, which is the European Rare Disease Organisation, recently did a survey with patients who are experiencing difficulty in Europe, and there are 2,000 patients who responded to that survey. 90 of them were Irish, and they had the highest rate of issues around access to specialist care. It wasn't around access to treatments or access to drugs, it was around access to specialist care. So we do have an issue here in that context. But if you, I'm thinking of the people outside, you know, and the people who have rare conditions, the people I know and interact with, and Avril and Tony know and interact with. It's really difficult when we live in a country where we don't have health information, when we don't have unique identifiers within our hospital system. If you have a rare condition and you visit one hospital and you go to another one the following week because you happen to be visiting a different time, you're in trouble. And I think, you know, so while it's not a rare disease issue, the Health Information Bill is really, really important. The implementation of it is even more important. The adoption of unique identifiers to ensure that every citizen in this country has their health information collected somewhere. And that's an area that is probably another discussion for another day, but in the context of rare conditions, it really matters. And the other process that's missing is health economics. Because in terms of orphan drugs, and those are the drugs, and there's only 72 of them since the orphan drug regulation, there aren't that many, there aren't treatments for every rare condition that are out there, there are only a few, and where there are, particularly for the ultra orphans, so where you're talking about maybe 1 in 50,000 people, they're high cost, there's less people with them, there's less people with the condition, so the cost to develop the drug is the same. And they're high cost. And in those situations, the system for assessment of those drugs is the same for any other drug. And it happens within the National Centre for Pharmacoeconomics. And yes, their process is transparent. We can see it. We can see what happened with the HTA analysis. What happens after that is the problem. It's the decision. And what was really good with the cystic fibrosis case is the people involved communicated with the patient organisation. But if you're a patient where there's only 2 or 3 of you in the country, and we've seen this, in the last 6 months we've seen this, those patients have nowhere to go to talk to the people who make the decisions. And I know the people around this table, both from the Department of Health and the HSE, have been working with us, in terms of how do we involve the patient within that. Because what happens then is they go to the public and they go to the media, which is what they're entitled to do. But really, we should have a process, and I think that issue is going to come up again and again in a country where budgets matter.
Avril, you wanted to come in?
Morning, Carol and committee members. I'd just like to pick up on Deputy Kelleher's point around research and whether we've made any progress around collaboration. And just to introduce myself briefly first, my name is Avril Kennan. I was a researcher in the genetics of rare diseases for many years and now work with the patient advocacy organisation, Deborah Ireland. My worry around research is that it'll be seen as a luxury in the context of the national plan. I think, under the current constraints, it's very easy to focus on the more immediate aspects, which are so important. But if we're seeing research as a sort of standalone item, then we're looking at it in the wrong way. It is actually integral to every single aspect of the plan. Obviously, going back to the developments made in understanding the genetics underlying rare conditions has been an absolutely essential element in progress towards diagnosis, and there's still many rare diseases for which the underlying causes are not known. There are still people out there who never get a diagnosis, so there's a huge amount of work to be done in that perspective. It's also around looking at our current support for patients, and the best way to do that is an evidence-based way where you actually analyse very carefully how are patients interacting with the health services, what are the quality of life issues for them, and then of course the thing that we all think about, the cures and the therapies, which are essential, and for some we've made great progress, for others we're still a very long way off. But even for those conditions that we're a long way off, we can't underestimate the hope factor. I always think it must be such a dark place for anybody living with a rare disease to know that there is nobody out there interested in your condition and doing something to try and progress treatments. So we still have a long way to go in terms of collaboration. I think we've made some progress in recent times, and we have a strong centre in UCD, for instance. But we're going to have to take a number of steps to improve things. And one of the main ones being to facilitate research within the health services, because we haven't been very good at that in Ireland. And I think, as John spoke about, we need to be doing research within the centres of expertise, because apart from anything else, that's been shown to improve patient care. We also need to, one of the recommendations in the national plan is to establish a network for rare disease researchers. So we need to think about that, and as you've all spoken about, the national office is not going to have the capability to do that in the short term, and yet by forming networks, that will open the door to EU funding. And actually, there is reasonable amounts of EU funding for rare disease now, but we have to ensure that our researchers are ready to take advantage of that. And then we also need to ensure that under the new strategy for science, technology and innovation, that our funding agencies have the capacity to fund rare disease research, because it has been very challenging to get funding for research on the more basic end of the spectrum in recent times. And finally, I would very much like to see a research representative on the proposed implementation plan and oversight committee for the